This is Brent of the Brookbush Institute, and in this video we're going to go over a joint-based manual therapy technique. If you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed professional with joint-based techniques within your scope. That means osteopaths, chiropractors, physical therapists, you're probably all in the clear. Physical therapy assistants, athletic trainers, massage therapists, you need to check with your governing body in your state or region to see whether this is within your scope of practice. Personal trainers, this is definitely not within your scope of practice. Of course, all professions could use this video for purely educational purposes to help with learning biomechanics, anatomy, and of course, palpation. In this video, we're going to do posterior to anterior mobilizations for the lumbar spine. That's both unilateral and central PAs. I think you guys are going to find, like all of the spine, that unilateral PAs or UPAs are the workhorse for our mobilizations of the spine. You're going to use those possibly the most frequently. I'm going to have my friend Melissa come out. She's going to help me demonstrate. The first thing we're going to talk about, of course, is position. So I'm going to have Melissa lie prone. If Melissa had pain and extension, I could put a bolster underneath her hips just to give us a little bit of flexion and me a little bit more room to be able to do these PAs without pushing her into her painful range. You guys will notice her arms are in a relaxed position. Now we have these really nice tables at Flex here in New York, and they have the arm drop downs. But if you didn't have those, this position is probably fine as long as somebody doesn't have a really tight shoulder girdle, or you could have their arms by their sides. The thing you want to keep away from is somebody putting their arms up, creating a lot of tension through their latissimus dorsi, because their latissimus dorsi does cross their lumbar spine. So tension here could make your mobilizations a little tougher. The other thing, you can go ahead and put your arms down in the arm cradle. The other thing you want to consider is that Melissa needs to be low enough on this table that I can get my chest over her spine so that when my arms are straight, all I have to do is rock my torso to get my mobilizations. So in essence, I'm using my body weight, the weight of my torso, to do my joint mobilizations and not my hands, like trying to do something like this. Right? I see people do that every once in a while, and I'm like, oh, you're gonna wear out your hands. Or they start trying to like tricep press down their mobilizations. I think you're gonna find it not only wears you out, it's almost impossible on bigger patients for the lumbar spine, because the lumbar spine is pretty strong and stiff to begin with. And I think you'll also find that your forces aren't very consistent. So if you're trying to do these nice consistent oscillations at the same depth with the same resistance so that you're consistent and reliable, you're going to have a hard time doing this as opposed to and then just rocking with your body weight. So the table's nice and low. Melissa's in good relaxed position. The next thing you guys probably want to do as a newer manual therapists, new to mobilizations, which I'm assuming you are kind of for these videos, you probably don't want to start by trying to palpate through clothing. Now, obviously we don't want to move clothing that people are uncomfortable with, but I can tell you adding a layer of clothing is just one more layer of stuff that we have to try to feel through. And if we're talking about pants, right, like if you have to try to feel through denim pants, forget it. Right, especially the L4, L5, L5, S1, and if you're doing SI joint mobilizations, trying to do those joints, which are already very strong, through denim is going to wear your hands out real quick. So what I'm going to do is have Melissa lift her shirt up just above the bottom of her rib cage, because by definition her lumbar spine would be below her rib cage, right? So the 12th rib, our last rib, hooks into our last thoracic vertebrae, and everything below that is lumbar spine. And then I'm going to have her flip the top of her waistband down. So she doesn't have to like pull down her pants. She just needs to flip her waistband down a little bit. And you know, if you have people come in workout clothes, sometimes these yoga pants do come up kind of high on females. So, you know, be aware of that and don't let that mess with your palpation. Make sure that you find the top of their iliac crests and that you can kind of get your thumbs down to the sacral base, even if it's just tucking just under the lip of their pants, that's okay. But you definitely need them to be enough out of the way that you can get to the lumbar spine without having to push through clothing. So the next thing we should probably think about is anatomy. Now, if you haven't looked at the lumbar spine in a little while, you don't remember how the spinous process and transverse process and where the facet joint is located and what muscles work around, I definitely suggest a little review. You could start with some of those soft tissue videos we did, the static release videos we did, maybe look at some of the anatomy of some of the muscles around the lumbar spine. And I've mentioned in our other spine videos, buying one of these plaster cast spines is really an invaluable tool. And I understand that this spine is not the same as Melissa's spine, and that the proportions are not identical, but you take a huge step forward in testing yourself with a plaster cast spine on, let's say, okay, I'm going to find, you know, my sacral base, and being able to look down and see if you're on the sacral base. Then you can test yourself, okay, I want to get onto L4, L5, so I'm going to go L5 spinous process, L4 spinous process, fall off, just lateral and inferior, and sure enough I'm on L4, L5 and I can look down. What you're doing when you do that is you're starting to create a visual model up here, which is going to help you match to what's underneath the soft tissue here. If you don't do that, it just takes a little bit more time, because this is essentially that with mush on top, mush being all the soft tissues, right? And all these lumbar extensors and multifidi, and you know, you got things like your quadratus lumborum, which are off to the side. And like, if you're not really kind of familiar and you haven't been doing a lot of manual techniques, it's nice to have that thing just to kind of to check things out. Now, let's talk about some of our first palpations here. If I find the bottom of my rib cage and follow those ribs up and just follow that, they kind of come at an angle like this, right? So I'm going to follow that angle up to that spinous process, and then I go down one. That's L1. So L1, L2, and I can feel a little like the spinous process are very flat tops. So what you're going to feel is like flat, and then there's a little divot. And then that's the next spinous process, and then a little divot. And then the next spinous process. So once you find L1, you can go, okay, L2, L3, L4. And hopefully what you'll do is, if you test yourself, you'll get to the sacrum, which starts to feel like a crocodile's back. It has like two ridges essentially, and it's like bumpier. It's not so flat with a divot, flat with a divot. It's not that consistent anymore. It's just bumpier down here, right? That's sacrum. Hopefully you get to L5 and then sacrum, and you're not like L6, L7. There's no L6 on most people. Every once in a while you meet somebody with an L6, but that's a pretty rare thing to come across. So count your lumbar vertebrae, and then maybe the next thing you want to try doing is finding the transverse process. Believe it or not, the lumbar vertebrae are wide. They're like really wide. Like the transverse process are wide as your fist. So you can get in here like this, and I can feel like that's bone out there, all the way out there. And I'll show you guys this in the close-up recap. Like they're wide. They're really wide. And feel it. You can get like L3, after L3 transverse process, now that we're on, you kind of run into the iliac crest here, and then they start getting hidden. So find the transverse process, find the spinous process, and then the next challenge would be to try to get your fingers on the facets. And the facets are going to feel like bumps a little more than a finger width from the spinous process. So if this is my spinous process, I want to go a finger width over, right? And then if we're going this way, the spinous, or the facet joint that's related to the spinous process that you were just on, is actually lateral and inferior just a little bit. Just a tiny, tiny bit. And once I'm over the top of them, then what I want you to do is gently kind of start trying to feel through all the soft tissue and see if you can get that joint to move a little bit. It does take a bit of force. It does take quite a bit of force. This is one of those things where having a mentor who's done this before is a really good thing, because I think people get scared pushing on the spine, and there's reason to be scared. Obviously, we don't want to damage anything. We don't want to hurt anybody, but to give you guys an idea, if I'm doing a central PA, I have to push Melissa pretty hard into the table. Like, I'm using quite a bit of my body weight to get to the end range of those facets that are associated with the L1 segment. How does that feel? Yeah, it's a significant amount of pressure. So let's talk about central PAs. Now that we kind of know transverse process, we know spinous process, we know roundabout where those facet joints are, let's start moving down and kind of talking about these different mobilizations. So you could do your central, what's called a central PA, on the spinous process with 2 thumbs, right? You just kind of come to either side and do it this way. I don't like to do that, and I'll tell you why. Anytime I can find a technique that doesn't require my thumbs, I use that technique. Because there are techniques where your thumbs are your only option, and your thumbs will wear out if that's all you ever use. So a lot of therapists get themselves into trouble because their IPs of their thumb, they start ending up with hyperextension, they can't really get stable, and it starts causing them a lot of pain in that joint. So for this one, I like what's called a pieziform handmade or cradle. I think it's called a cradle saddle grip maybe is the right term. What I do is I put this part of my hand, right about where your pieziform is, over the spinous process. Now that's pretty comfortable for the patient too, because I'm pretty much just pushing them into the soft tissue of my hyperthenar eminence there, right? Like the mush underneath my pinky finger. And then to use both of my hands, I'm going to take this hand and it's going to saddle over the top of my hand like so. And now when I get into position, I can just use my body weight. Right, so you guys see that? This is what I'm pushing with, but this is where my force is coming from. Straighten out both my arms, and now I can do my central PAs. Now I have to admit, usually central PAs I don't use unless somebody's super, super stiff. I more use these as part of my passive accessory motion exams where I go, okay, please tell me the difference between pressure and pain, right? And I'll push down, and what's that, pressure or your symptoms? That's symptoms? Okay, so that's symptoms. And then I start moving down. Pressure or symptoms? Pressure. 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 Good. So we know in her case, or at least we're going to take a guess in her case, that most of her pain is coming through that thoracolumbar junction, somewhere at like the L1 segment. So I'm going to want to start thinking about what dysfunction happens there. Unfortunately, hypermobility is actually more common at that segment, but the next thing to do would be, okay, do I feel like that segment was hypermobile or hypomobile? The only way you're going to know that is from experience, and you do have to keep in mind that palpation is probably our least reliable assessment. So this is one of those situations where I may do mobilizations and then immediately retest, just mobilize that one segment for 30 to 60 seconds, have them get up and see if I can reproduce their pain. If they got better, then we're on the right track. If they didn't, then maybe the segment is hypermobile. We need to start thinking more towards stabilization exercise. So again, central PAs, guys, just thenar eminence over like this, and then I use this like this, and then I'm going to push down to end range if I'm doing an exam and see where pain comes from. But if I was doing mobilizations, you guys know that it's 50%. All right, so first resistance barrier, end of arthrokinematic range, which is there for her, back off to 50%, and then I can either do my grade 3 by backing back off to the first resistance barrier and pushing down to 50%, so that's my larger amplitude but less intense mobilization because I'm backing all the way off to essentially no resistance. Or I can get a little bit more intense by going right up to 50% or maybe even a little deeper and staying there with small amplitude mobilizations. right? And then see how that feels. And she actually does feel kind of stiff, so I might try this and then see how she does. And you guys can follow this technique all the way down. So what I'll do is if I'm trying to do more segments in the spine, test, and then I put my 2 fingers like that, right? So my pisiform hammate's under the spinous process. I just take my 2 fingers, find the next one down, move, and go. 2 fingers down, go. 2 fingers down, go. And you can see I can address the whole spine real quick there. Now, let's go back to the workhorse technique of UPAs. A lot of lumbar spine issues tend to be asymmetrical. You have restriction on rotation to one side, or at least one side's more restricted than the other, or lateral flexion is more restricted to one side than the other. We start looking towards these unilateral posterior to anterior mobilizations. This is where I'm going to have to use like a thumb over thumb technique. So I'm going to find spinous process. Now we know in her case, her symptoms seem to be coming from somewhere around the L1 segment. So maybe I start with L1, L2 facet. Push down, find the first resistance barrier, find the end. How you feeling? Yep, that's a little bit of her symptoms, all right? And then maybe I start my grade 3 mobilizations, assuming that it's hypomobility, right? Despite the fact that she has pain there, it's not pain. I don't run into pain before I run into her mobility issues. It's like as I get to the end of her range, she starts having pain, which tends to be stiffness dominance if you're talking about like a Maitland approach. So what I might do is do 10 or 15 seconds worth of this and then ask Melissa, does that feel like it's getting better or getting worse? Better. Okay, so if it's getting better, then I'll keep doing it and then of course retest. I could go up. Guys, the mobilization technique here is the same for T11, T12, T10, T11, like it's the same unilateral PA, so I could go up a couple segments, I could go down a couple segments, I could try the other side. Of course, I would walk to the other side of the table. But again, notice that all I had to keep in mind was my anatomy, which is this facet is just lateral and inferior. If I'm talking L1, L2, if I wanted to go T12, L1, then I'd have to go lateral and up just a tiny bit. I'm keeping thumb over thumb so that I'm using both thumbs and I have as much strength in my hands as I possibly can. My arms are practically straight and I'm just using the weight of my torso to do the mobilization for me, keeping my protocols in mind. Notice I'm not doing this, I'm not doing this, right? That's all really bad technique. In fact, for some individuals, guys, if you wanted to try this, you could use the hand position we used on the static release videos, which is dummy thumb with in between our inner thenar groove applying the force. On some individuals, you might be able to get your hands into the right position to not have to use thumbs at all in a straight up and down position. You're essentially using this as a little point that you're then pressing into with this. And sometimes that's a little bit more comfortable for individuals. You could try maybe a little less specific, going off to the side and pressing on the transverse process with the pisiform hamate grip that we just talked about with the saddle grip. Keep all this stuff in mind, although it's not as specific as this, and I know some of you guys are thinking, well, why wouldn't I just use the best technique? The truth of the matter is you're gonna get tired, and if your thumbs hurt and it's the end of a long day and you've had a lot of big individuals on your table or a lot of stiff patients, or maybe it's the end of a long week, maybe you happen to be the athletic trainer or physical therapist for like a football team and everybody you treat is just a really large human being, keep these other techniques in mind, man. A good technique is better than nothing. Even if it's not, don't let perfect be the enemy of the good is essentially what I'm trying to say. Let me show you guys just a couple more things here, just some special palpations to keep in mind. If you find the top of the iliac crest, right, and you keep following down, you'll eventually run into the PSIS. If you find the space that's kind of between the top-ish of the posterior iliac spine, the PSIS, and then these spinous process here, right? What we're on, this is L4 and L5. You guys will be able to feel this a lot better than I'm showing it to you. But there's like a little place in between all of this bone mass that you start running into here. And in there is your L4, L5 facet. It is definitely worth testing that facet. People forget about that facet. People will do all of this stuff because it's easy to access. And then they'll kind of forget that they need to get in there and really search for that facet specifically. How does that feel? That feels really stiff to me. So, you know, she doesn't have pain, but maybe she's getting hypermobile here because this is super stiff. I would check on it. Now the same thing with L5S1. So find that triangular space that's kind of between PSIS, the top of the posterior iliac crest, and the spinous process that's just lateral to it. Find that space. And then what I want you guys to do is find the sacral base. And I want you to keep feeling up the sacral base until you fall off it. And that's L5S1. And now realize L5S1, you might have to go a little bit this way to get that to move the way you want it to move. Again, these are worth checking. They are the two segments most likely to be hypermobile, but they also have a propensity to become hypomobile. It just depends on the condition. It's a 50-50 shot. So if you feel like you got normal or more motion than normal when you press into them, then leave them alone, because you can definitely make somebody worse by making them more hypermobile. But I don't know that I would ever rely completely on central PAs without at least checking L5S1, L4, L5 facet, just to make sure everything is in good working order. All right, guys, so stay tuned for the close-up recap. Okay, for our close-up recap, guys, we have the lumbar spine. You can see how it's nice and visible here. The first thing that we talked about finding was maybe L1, right? And we did that by following the last rib up to the spinous process of T12, right? Because the last rib would hook into our last thoracic vertebrae. And the next spinous process we feel, right? So kind of flattish spinous process, divot. Spinous process would be our first lumbar spinous process. And then we started by talking about central PAs, which, you know, I told you guys could use your thumbs like so, right? Put one on either side. Don't press down on a spinous process like that. That's very pokey. But if you go this way, on just either side of the spinous process, you guys can notice there's a little bit of skin there in the middle. You could do it that way, although that's tougher on your thumbs than you need to be. I would go ahead and put your pisiform hamate spot, right? This mush of hyperthenar meat right here, right over the top of the spinous process. And then you can saddle it up like this. And then you get just that nice lean with your chest over top of where you're trying to mobilize. And you can just use your body weight. Real easy. And of course, once we found one spinous process, it's real easy to go, okay, spinous process, divot, next spinous process, divot, next spinous process, divot, next spinous process. And keep in mind, guys, the spinous process, right, takes up a lot more space than the tiny little divot in between spinous processes. Now, the next thing we talked about finding was your transverse process, which, believe it or not, come out about yay wide. They're really wide. Like, this is me rocking Melissa's lumbar vertebrae here. Right? And you can see my hands they're a fair amount apart. Like, they're her fist width. Not quite my fist width, but her fist width apart. Nice big lumbar vertebrae with nice wide transverse process. And we can use transverse process to do UPAs. That is something that you're going to want to consider, especially if your thumbs start getting tired. You need to switch to something like this position. This tends to work a little bit better using a transverse process than trying to like get into a facet joint, because once you guys are looking for facet joints, right, and you're falling off that spinous process about a finger's width away, you'll feel that bump. You can go this way a little bit and feel a bump. You pretty much have to use your thumbs to fit in there. Otherwise, this becomes tough. You end up getting multiple segments. Not that that's a bad thing, providing they're stiff at all those segments, but this is a bit more specific. All right, so we have spinous process. We have transverse process that come all the way out here. And then we could go to facets in here. All right, I'm going to show you this on the other side, although I'm on the opposite side of this individual. I wouldn't do these mobilizations this way. So spinous process, transverse process is all the way out here. And then the facet is about right there. All right, so I hope that helps you guys with your proportions a little bit. Now I did show you a couple special techniques. You know, we have the top of the iliac crest here. In line with the top of the iliac crest is like the spinous process of L3, L4. If you go just below the spinous process of L4, so you kind of draw a triangle between that spinous process, the top of the back of the iliac crest here. There's like this little triangle section that's like leading into the bony sacroiliac joint and the bony PSIS. This little spot of still soft tissue. At the bottom of that is the facet of L4, L5. I would keep that in mind because that's one of those segments that people forget to palpate. They're palpating down, palpating down, palpating down, and then they stop because they either accidentally hit the iliac crest, maybe they were too wide to begin with and they were pressing on transverse process instead of facets, right? So they get to the iliac crest and they stop. Keep that L4, L5 facet in mind. And then the other thing I want you guys to do is make sure that you find the sacral base, which you know you're going to come off the flat sacrum, and then just fall off the top of it so that you find L5, S1. Now those are the two joints most likely to become hypermobile, but in a lot of individuals with a chronic history of lumbar pathology, they can also get stiff. So knowing how to palpate and then mobilize L4, L5, and L5 and S1 are important techniques to have in your arsenal. Of course, the technique that we use is the same as all of the other vertebral UPAs that we've done. Once you find that facet, find the first resistance barrier, and then find the end of arthrokinematic range, and you're going to have to press down pretty good in the lumbar spine. This is one of those techniques that having a good mentor will definitely give you the confidence to push this to end range, and then you'll back off to 50% between, and then you can do your grade 4s right there at 50%, or you can back off to 0 resistance and go to 50% in like a grade 3. And of course, make sure you follow through your protocols, getting a increase in joint mobility before you stop, probably 30 seconds or more. So there you have it. Assess, address, reassess. Make sure that every time you choose a joint-based manual therapy technique, it is based on an assessment and that you return to that assessment after you finish the intervention to see if it was effective for the individual, the patient or client that you have in front of you. Ensure that you continue to learn your anatomy, because your anatomy is going to help you with your hand placement, with understanding what a joint can do, with understanding what you may gain from this particular technique, and of course, practice. You have to practice these techniques, hopefully not for the first time on a patient or client who just walked in the door. If you can, find a more senior instructor or a mentor to give you some really good hands-on instruction. Use your peers for some good feedback. And of course, always look for live education to help with your manual therapy techniques. I know these videos make education very convenient, but there is no substitute for learning manual therapy in a live setting. I look forward to talking to you guys again soon.